Perfect. All right. So as I was saying, the washer here, they're the only kind of washers you can use. You always want to look, and you can take it off if you want and look at it, but you always want to look at the washer if you're changing the cylinder. Make sure the rubber's not ripped or torn. Make sure it's not all puffed up over that center hole that it's on. This is what's going to create the tight seal between your connections. So your gas is going to leave the cylinder and it's going to enter into this hole, and the rubber is the only thing that can kind of squish around the outside of it to create that good seal. Hard plastic just can't do that. So you're going to use these rubber yoke washers. They are reusable. So as long as there's no rips, like if it looks just like this, you can reuse them. Some facilities say, no, I'm just going to replace it every time I replace a cylinder. They're $3. It's up to you completely. Just know you can reuse them or you can just replace them every time, but you want to make sure they look good, right? That none of it's, you can kind of tell too when they get corroded. You can tell when they get all puffy. So you would want to replace it if it looked like that. Okay. Once you're sure that you have your washer and it's good, right below the washer are these two pins. These pins are the pin indexing. So I mentioned before, you can only put oxygen on the oxygen side and nitrous on the nitrous side. That's a safety feature just to protect the patient from cross connection of gas, right? And so ultimately these pins are what you're going to be lining up with these pinholes on your cylinders. You always want the holes portion of your cylinder to be facing towards your platform, right? One of the things is when you open up a new cylinder, a brand new cylinder, a full cylinder, kind of the only way you know that nitrous is a full cylinder is if that plastic wrap is still around the neck of the cylinder. Okay, when these when these cylinders go to plants to be filled, once they're full, they put a plastic around this neck, this stem, to cover the holes from and to prevent dirt and debris during transport and during storage from getting in those holes. Okay, so if that plastic wrap is still on that neck of it, that's going to be your best clue that that has not been tapped into, that is indeed a full cylinder. And so you would peel that plastic wrap off of the new cylinder. There might be a little plastic washer. Again, you're throwing the washer away with the plastic wrap, and then you're facing your cylinder towards your washer and towards these pins. When you do this, you've kind of got to, it takes a little up and down motion. Do your best to get your pins into the pinholes and then make sure your washer is lined up with this larger hole. The hardest part about this is sometimes what happens is you can see these little ledges underneath here. A lot of times people will think the pins are in the pinholes because they'll feel that catch. And the pins are actually, basically the cylinder is resting on the pins, okay? So if that ever happens, the little swivel bar will not close. So if you can't get that swivel bar to close, you need to take a closer look at your cylinder and make sure the pins are actually in the pinholes and that your washer is actually lined up. More times than not, if you're sitting on those pins instead of in those pins, you'll see actually the cylinder hole right here. You'll see it if you look this way, right away from this platform. All right, so once you get them in, of course, then that's when I mentioned you're swiveling your bar shut and you're making sure you pull that bar towards you. Oh, okay, we're having all kinds of fun issues here, aren't we? Let me see. Oh, okay, when you pull that towards you, right, that will then basically allow you to tighten that T-handle down. And so as you tighten the T-handle down, now don't go crazy on the T-handle, right? When you tighten it down, a lot of people just crank on that black T-handle. And the problem with that is that ultimately when you're doing that, what you're doing is you're pushing that cylinder into the platform, which is fine. The problem is you're squishing your washer. And so your washer is going to end up kind of going into the hole, and you'll see a great big kind of ridge in your washer when you take that cylinder off, or that's when it might potentially get all puffed up and has potential to tear the more tight you get it. Okay. I have gone to facilities pre-COVID when I could do this in person, and Biomed like literally was the first people to put this on, and they put that so tight that they already ripped the washers, like they were already ripped. So just again, it's just a hand tighten. Once you meet good resistance and you can't really go, don't keep cranking on it, just leave it there and you're good to go. You will know, because what I typically do is when you change your cylinder, I would wrench it open to make sure you don't hear any hissing before you leave it in your cabinet, right? So again, you're putting it away after you're changing the cylinder. More than likely, you're putting it away. Just double check to make sure when you open your cylinder, there's no hissing, to make sure you connected it right, so that the next person doesn't go to open it and have it be hissing, right? So check it. Make sure you're not hissing, you're good to go. You can put the device then away, and that is changing your cylinder, okay? Here's that swivel bar. Here's kind of a top view picture of what I'm talking about. You gotta pull that bar towards you so that there's a little bit of space and a little bit of space. As that lubrication wears off, this is gonna get stuck back here, but instead, it's not gonna give you this space right here. And then this bar you can see is kind of at an angle. That's what's gonna leak. So your washer is your #1 source of potential leak when you open up your cylinder, and your basically that bar being at an angle. So if you ever see that bar, you pull it out of storage and that bar is at an angle when you go to open it, don't open it. Make sure it's closed. Automatically, readjust this to pull it straight and tighten it down, okay? If it still hisses, so when you're setting up, if you're getting any kind of hissing with this gas, or maybe when you change your cylinder, just immediately close it. And again, make sure your bar is straight and make sure you have a good washer, okay? All right, let's talk about nitrous oxide, the gas itself. Nitrous oxide is a colorless, odorless gas. Some say it does have a smell. Usually they're smelling the mask or the circuitry, and the gas is non-flammable. The way it works is it's absorbed by inhalation and then it's quickly eliminated via the lungs. So it's not really metabolized by the body. That means what the patient breathes in is pretty much identical to what they're going to exhale out. And so that's why we have this scavenger. That's going to take away the bulk of their breath. They can absolutely take breaks from using the system. They would just breathe their last breath in, exhale it out fully, and then remove the mask, okay? What you don't want to see them doing is breathing it in and then answering your question with the mask over here. You don't want to see them breathing it in and blowing it out into the room, right? Breathe in and out, and ultimately then that vacuum system can take that gas away. All right, and so you won't be exposed. The great part about this not being metabolized is that this is super safe for both mom and baby. Okay, you are not going to see it flatline like you do with fentanyl or Stadol, and you're not going to see sleepiness from baby, even if she utilized this right up to her last push. Half-life is just too short. The amount that's crossing that barrier and getting in there is just too minuscule. You won't see a response. Very safe for baby. And ultimately, this is quickly out of the system, right? So it's quick in and quick out. The great part about that is no long post-monitoring times. So ultimately, they use it, they stop breathing it, 3 to 5 minutes later, it's completely out of their system. You could switch to another drug, or, if they're done with labor, you can ultimately just put it away. 3 to 5 minutes later, they're back to their baseline. Quickly in, when I say quickly in, may start taking effect 20 to 30 seconds into breathing it, take a little bit of the edge off. That being said, it does take 1 to 2 minutes for this to be at peak benefit, right? So if we're trying to get a couple of minutes ahead of the peak of the contraction, we're going to be breathing it ahead of the contraction. If you wait to the start of the contraction, you're never kind of going to reach the best benefit that this can do for that patient, simply because by the time you're a couple of minutes in, that contraction is gone, right? So you want her breathing ahead of it. As the contractions get closer and closer together, you can encourage her to breathe it between the contractions. She builds it up in her system as she's resting. And then once that contraction hits, she could just set it aside and focus on getting through that contraction, okay? Or if she's pushing, same thing. Builds it up during her rest period, sets it aside, bears down, and pushes, okay? So in order to get the best benefit, your goal is to be a couple of minutes in at peak benefit at the peak of the contractions, and that's part of coaching. Once she gets the hang of it, she'll have the hang of it. It won't take a whole ton to get her, and she'll know when she has waited too long to put it up there as well. Okay. Now, this is important to know. This is not going to eliminate pain. Most patients know they're in pain. They just don't care anymore. This just kind of takes away that, I call it give a hoot factor. And it really helps your patient disassociate from the pain. Light and floaty is the most common feeling. Tingly is common, or heavy and weighted feeling is also common. And, you know, really it can be a little bit out of body type of feel as well. So adverse reactions do include dizziness, nausea, vomiting, headache. Low percent risk of using or of having that when you're using 50% nitrous or less, which is what this is. So you got about they say it's about an 8% risk of running into one or more of these side effects. Okay. Two things that would increase that risk are higher nitrous percentage, which we don't have to worry about because this system cannot offer a higher nitrous percentage. And in fact, it is important to know that this system has a device called the fail-safe mechanism inside that prevents the patient from getting anything more than that 50% nitrous. So if something happens with your oxygen, let's say your wall source oxygen just completely stops, all flow would stop going out to the patient. And that's just that fail-safe mechanism protecting them from getting 100% nitrous oxide, right? And so not only can we not have a higher nitrous percentage, but the other thing that would cause potentially your patient to be at a higher risk of these adverse reactions would be the procedural length time. So if they're just puffing away at this, and ultimately you can't get them to take any breaks, you know, they will start to potentially run into a higher risk of running into these side effects. If they don't have those side effects, then that's really, you know, their only risk to just continuously breathing it. But the longer they breathe it, the more chance they are of running into these. Just so you know, if your patient is like, I'm gonna throw up, they look super, they're very dizzy, they look green, you know, they feel like they're gonna vomit. What you can do is you can wrench close your nitrous oxide cylinder, have them keep breathing. That will give them 100% oxygen. Remember, oxygen is our reversal agent for nitrous oxide. So very quickly, if you give this patient 100% oxygen, either by closing your nitrous cylinder or just by throwing a non-rebreather on them instead, that will quickly dissipate and wash out the nitrous from their lungs. Within a minute or two, they'll be feeling much better. If they want to continue to use it, which is probably unlikely, but if they did, they would just want to take more breaks, right? And not run into that, okay? Also, it is super common for hospitals to use Zofran in conjunction with nitrous oxide. I would say probably at least 50% of my hospitals just automatically order Zofran anytime the nitrous is ordered. And that's just to kind of ward off running into any of these adverse reactions. All right. You know, benefits of using this in a hospital is this is just another pain management tool in your toolbox. It's really a good first go-to tool in your toolbox, which I'll explain on the next slide, which is the last slide. But ultimately, this has a super long, safe track record of use. This was used years ago in the United States. And then what happened is epidurals came into play. And when epidurals came into play, the thought process was, well, why have pain when we can have no pain at all? Then what happened is you know, it went to the wayside. Overseas, this never left. This has always been one of their main methods of labor pain management. And in fact, many of the countries with a socialized medicine or a universal healthcare, this is actually all that they offer. And that's because it's a very cheap and inexpensive gas, and it's an inexpensive option, okay? But now since 2015, this has come sweeping back to the United States. We have thousands of these all across the United States, and ultimately super long safe track record of use with no incidences. All right, easy to administer. Even though this is a long in service, this is super easy to set up, right? You're just opening your cylinder, you're plugging in your gas sources, you're attaching your device or your circuit, and you're handing it to the patient. So, right, those 5-step process to setting it up, super easy. Quickly in, as I already mentioned, quickly out of the system, as I already mentioned. very few contraindications. You're going to want to know those contraindications. Know who's vetting the patient for those contraindications. Is it the nursing staff bringing it to the providers? Is the provider staff have a list that they're going through to make sure ahead of time, right? Who's following up on those contraindications? And then the last slide here is the spectrum of sedation scale. The spectrum of sedation scale ultimately follows the, for nitrous oxide, ultimately follows the ASA guidelines, which says that nitrous oxide 50% or less falls into this minimal sedation category. So your patient's going to respond normally to verbal commands. Their airway will be maintained at all times when utilizing this device, okay? It's considered minimal sedation as long as it's the only thing in their patient's system, that there's no other opioid or sedative in the patient's system. All right. And so what happens is if you would add an opioid or sedative to the patient's system, you would potentially change the sedation level to a moderate sedation. And that in most facilities is outside of nursing scope of practice to administer. So even though a provider is always ordering this, and even though the patient is always self-administering it, nursing is typically the ones on the books as administering this gas, okay? The ones that are actually considered administering. And what is their scope of practice is minimal sedation, okay? And so you don't want to get into that moderate sedation. So this is why I say nitrous is your good first go-to, because you can immediately switch to something else, because nitrous oxide, you breathe it, let's say she loves it, but it's kind of ran its course and she wants to switch to something else. She just stops breathing it. And the time that it takes you to go get your fentanyl, Stadol, Dilaudid, whatever you use, this is out of her system. You can immediately switch over to something else. Where in reverse, because they can't overlap, right? You've got to wait essentially dose time. So your policy might specify an hour or 2 hours, but it's really however long that drug is going to be in that system. If it's a 2-hour drug, ultimately, and it's 2 hours before you can give another dose of the same drug, you should not administer nitrous in that time frame, okay? And that's because they'll overlap. That'll be outside of nursing scope of practice to administer. You would need anesthesia or a provider that has conscious sedation or moderate sedation privileges to be present, which doesn't happen very often in very many places, okay? So your policy more than likely specifies that you're not going to use an opioid within an X amount of time of administering nitrous oxide. You're not going to use nitrous oxide within that time that you've administered another gas or another drug. Gosh, I'm getting fumbled here. All right. So uses of this, right? This is used for all stages of labor. So you have a mom who's only a couple centimeters dilated, but maybe she lives a ways away from the hospital. So you're not going to send her home because she's already, her water's already broke and everything. You're just going to have her stay there and kind of watch labor progress, right? This is a great option to kind of take that edge off, take away that anxiety about what's happening, get her to relax and allow, labor to advance, okay? Or your mom who wants to go all natural and maybe she hits transition and she changes her mind. This is a super safe, non-invasive measure that will help her potentially get up over that hump and just take a little bit of the edge off, right? It's not going to dampen her experience because it's not going to eliminate pain, but it's going to make it take that little bit of edge off, right? And then potentially she could use it through the end. Or your mom who comes in from the parking lot. She just about gave birth in the truck and she's already almost there. Ultimately, this is quick, easy to set up, easy to use quickly in the system. And you don't need the IV unless your policy specifies to have this in place. And so ultimately quickly in the system. And then the great part about this is you're not going to have long post monitoring times, because if she's that close and baby's just about out, right, you can utilize this for her repair. And ultimately, when you're done with it, you're done. You don't have those long post monitoring times because you gave her something else. It is, again, used for repairs, used for tough placentas. It's used for aversions. It's used for balloon placement. And it's used if you check her, and every time you check her, she's climbing up the head of the bed. This is an option for her. And it's actually used all over the hospital for IV starts and catheter placements. And that is just simply because, you know, it has a vasodilation effect. It's not a true vasodilator, but what happens is ultimately you've got a patient that knows they're a hard stick. They're, you know, constricted because they're anxious about this. If you administer nitrous, it takes away that anxiety, allows them to relax. When they relax, they stop constricting, and then all of a sudden the veins that weren't there are there because they stopped constricting. Okay, so it's not a true vasodilator, but know that it is used all over the hospital for that that purpose, right? So lots of uses outside of just straightforward labor contraction pains. Okay, that is all I have for you all. Any questions that you want on the recording, Cindy?
Not right now. Thank you, Krista.
Awesome. I'm going to stop sharing and I will stop